warahmatullahi wabarakatuh. My name is Ashraf Al-Zahabi. It gives me a great pleasure to chair the session of today, which is a respiratory webinar organized by Exeltis and endorsed by the Emirates Thoracic Society, our colleagues from the United Arab Emirates and Lebanon and other countries joining us tonight. Tonight's session is interesting, and we have two topics to discuss. The first topic is on the science behind corticosteroids and long-acting beta agonist, and that's going to be delivered by Professor Qutaiba Hamid. And the second session is going to be an update on guidelines on both asthma and COPD, and this is going to be delivered by Dr. Bassam Mahboob. And this is going to be followed by Dr. Wael Khattab, who's going to speak to us for a few minutes at the end of these two talks, and he's going to go over Exeltis respiratory portfolio in the region. I'd like to introduce our first speaker today for the science behind ICS and LABA. And
I'd like to thank the chair for introducing me. Thank you, Dr. Ashraf. I'd like to thank the organizers and the sponsor for inviting me to give this bronchodilator for a long time. And we still have problem with asthma. So today I would like to say why we are using them. A lot of us use those things, but they don't know why. And that's why we are failing to control the disease. So I'd like to highlight also how can we improve the delivery of these two drugs, the combination therapy, the deposition of that, and the aim is really to control better asthma, which we see every day. And I would like to end up by saying, is there a role for these bronchodilators, LABAs, and other bronchodilators, and inhaled corticosteroid in COPD? This is a bit controversial area. So let's start with asthma. Everybody, we know that asthma is a combination. The reason we have asthma, people have asthma, is that it is a combination of genetic background and environmental interaction. So many years ago, I remember in the 80s, we thought asthma is a genetic disease and we can control it by controlling the gene. However, I just want to show you this slide to show why we're having this. We have many genes there, and now we know that asthma is not a single genetic disease. Asthma has a number of genes that it would be very difficult to control asthma or COPD through inhibiting or knocking down the gene. Now the other you block me now. Environmental factors play even a major role in really initiating this disease. And one of the main environmental factors is atopy. We know that atopy and allergy, one of the main reasons. However, there's other factors, particularly in the last 2 years, in countries like the UAE, like Lebanon, there are other places which has really contributed to increase the incidence and the severity of the disease. And one of these factors is smoking. I don't want to speak about shisha, but I know it's very common there. Also, what we call the hygiene theory. Basically, a lot of people move from the villages to the town, and then now we are living in a more clean environment. We are not exposed to the right pathogens, so that will really affect our immune system, and that's why we are seeing a lot of allergy in the pediatric population, in the adults. The other thing which also very relevant to our part of the world is pollutions, and now probably, I don't know people in the UAE, I work in Sharjah. When you go from Sharjah to Dubai or even in Lebanon or in Cairo, when you go and you see all these cars, the pollution is a major problem. Now, the other factor that has also contributed to increasing the incidence of asthma, these are, I'm going to discuss those one in relation to the pathogenesis of asthma, is the obesity and also the type of food we are eating. We are eating a lot of fast food, and then the obesity is a major problem of our patients, of our pediatric population. 35% of our children are obese, and as you know, obesity is a major source of inflammatory mediators that contribute. You know, rarely people cook now at home. Most of the people, you know, I always say my mother used to cook every day. My wife cook every other day. My daughter, who's a doctor, she cook every week. So this is another factor, everybody, you know, trying to get the fast food. Now, the other thing that also we don't know a lot about them in our area is what we call the sandstorm, and these have another factor that contributes. So all these are environmental factors that have contributed to increase the incidence of the disease. And Dr. Ashraf is one of the people who have looked into the incidence in the UAE and shows that there is an increase in the incidence of the disease. In Saudi Arabia, for example, 24% of pediatric population have asthma. This is really a very high incidence, and also there is a high incidence in the adult. But most importantly, as you're going to see, we are seeing more of severe asthma that we cannot really treat. Now, other two interesting things which is relevant to our area, and we should look at it carefully here before we look to the medication, is the vitamin D deficiency. And in a study that we recently performed, me and Dr. Ashraf and Dr. Bassam, I was astonished by the low concentration of vitamin D in our UAE population. And we know that vitamin D is an anti-inflammatory. And in fact, in those patients in our study that we show is that when you replace the vitamin D, you can control asthma better. The other one, which is a bit strange in the last few years that we have been also contributing to the disease, is the way that we deliver our children. You know, they have found that children who are born by cesarean section, they have higher incidence of allergy and asthma. And that is, to explain that is very simple, because, you know, these children, they go through the right passages and they are not exposed to the pathogens that are present in the right passages, and then they will end up with probably a low immunity. So it is all about the immunity of the body. So if we really, people and many countries have tried to control the disease through the control of the environment. Unfortunately, most of the country, I lived for almost 30 years in Canada, even in Canada, you know, with all the measure to control the environment, they really did not manage to control the disease. Now, as I said, in the genetics, it was very difficult to do anything to change the genetics. So they thought with the environment that they can do, but you know, we all live into a very fast world and a lot of technology, a lot of industry, a lot of, you know, we are all busy, but everybody want to do the quickest thing. So what's left with us is really what we have been doing in the last, is trying to improve the medication. And for many years now, and I'm not discussing something new, the hallmark of treating asthma has been bronchodilators and inhaled corticosteroid, although as you're going to see probably, but Sam will discuss with you that not all the patients responding to those two combinations. Now, if we have many of these sort of combination, many company has really combined LABA and inhaled corticosteroid, and you are dealing today with another combination, is why we are failing to control the disease. I think what we need to do is to find a better way to a combination, is to not only to give it to the patient, but to educate those patients, to improve the deposition of the drug to the whole airway, particularly the small airway, and also to improve the compliance. You know, a lot of people, when you ask them, they say, yes, we take our drugs. In a study that we performed in Canada many years ago, where we put with those inhaler chips that can really detect, we were spying on the patients, and chips that can detect, and even in the most educated patients, 30% are not complying with the disease. In some study, they found 50% actually. I don't know, maybe Dr. Ashraf, Dr. Bassam has more experience. So if we find any way by using a new device, by using a new combination that allow us to improve our sort of the compliance of the patient, I think we can have better control of the disease, and we will need to use biological drugs less often. Now, to know, a lot of actually doctors, including my daughter and other people, they give inhaled corticosteroid and LABA or short-acting bronchodilator or, sort of like LAMA, and they really don't know the molecular basis. And somebody might say, why should I know the molecular basis? Unless you know the molecular basis and the pathological basis, you are not knowing what you are treating. And you might end up treating the symptoms. And that is one of our major problems. If you only treat the symptoms, thus you're going to see that you're going to even let this drug, this disease be more chronic and more severe. Now, to have an insight in what's happening in the lung, many years ago, we adopted, people use animal model. I'm not going to go through that because human is different here. But what we have been using is we were been bronchoscoping our patient, the asthmatic, and taking biopsy from this asthmatic individual and to study them in the lab to see what we are treating. What is the molecular basis of using all these bronchodilators? And just to remind you, I'm sure you're all familiar with the pathogenesis of asthma, but to remind you is the hallmark of this asthmatic individual is this, what you see here, inflammatory cells there. A number of inflammatory cells, including those red cells and those blue cells, are accumulating. If you look to the lung, normal lung, you see probably few cells there. But in asthmatic, you can see this sort of infiltration of these inflammatory cells. And that is always what we say, inflammation is the hallmark of asthma. So we need a drug, as we're going to see, to be deposited and to be effective in treating this inflammation if we want to control asthma. Now, the other major pathological changes that we are seeing is, as you know, the airway is surrounded by smooth muscles, and those are usually a thin layer of a smooth muscle. In asthmatic, those smooth muscles, and you're going to see why they get so thick, those smooth muscles, they get thicker and thicker, and that's what we call airway remodeling. Now, the airway remodeling involves subepithelial fibrosis, the one you see here, and also all these smooth muscle proliferation and migration and also thickening. So we need to deal with these two pathological changes. Now, why smooth muscle is important? Because, this airway, when you have these smooth muscles surrounding it like this with a lot of remodeling, it will be very easy constrict in response to an antigen, an allergen, or any sort of inhaled particles. And if the patient is predisposed here, this is going to be constricted easily, and it will be difficult for this one to be relaxed also because of this way of the remodeling. And that is not only happening, as you see in the major airway, but it could happen, as you're going to see, in the small airway. Now, if you go to the inflammation, not every cell is responsive to inhaled corticosteroid. One of the most sensitive cells that respond to steroid is eosinophil. And in asthmatic, you cannot see most of the asthmatic. This is a biopsy that we took from an asthmatic individual, and those red cells are what we call the eosinophils. So eosinophils infiltrate the wall of the airways in response to allergen. They migrate from the blood here. And so what? I mean, if you can see eosinophils in the uterus, in the bowel, but you can never see eosinophils in the lung, in the normal lung, only in asthmatic and in allergic diseases. Now, these eosinophils not only deposited in the large airway, but they go to the small airways. And in fact, this is something that I would like to highlight, and maybe we're going to discuss later in the guidelines, that asthma is not only a major airway disease. A lot of the patients, this is a patient who died from asthma. He didn't die from the major airway. He died from those small airway, which are thousands and millions of these airways are distributed. And if you can see here, if we follow it to the small airway, even to the ducts, the small duct eosinophil go there. So the concept has changed in the last probably 10 years from asthma being a major airway disease to be a sort of a disease that can affect the major airway, as I show you, and can affect also the small airway. Not only that, but now I am sure you all hear that 80% of asthmatic individuals have also inflammation of their nose, and that is the basis of what we call united airway theory or systemic allergy. Now, steroid, fortunately, inhaled steroids and topical steroid, they work on these eosinophils and they remove those eosinophils, as you're going to see in most of the cases. So if we have an eosinophils, if we detect the eosinophil in sputum or in the lung or in the blood, most likely that these patients will respond to inhaled corticosteroids. Now, these eosinophils, if you look at them, they are not there, but the way they come here, just to give you an example where we can block them, they come from the bone marrow and they sit in the blood. And once you get inhaled an allergen, you are close to a cat, you are close to a ragweed or to grass pollen, you inhale a grass pollen. This will stimulate a number of mediator, as you're going to see, and they will make those eosinophils come and sit to the endothelium of the airways there, and then they migrate the endothelium to the wall, and they sit there. And during this process, they release a lot of mediator. A lot of them cause constriction of the airways. So as far as there is a activated eosinophil here, there will be a constriction of the airway and what we call late phase response until they will be released outside to the lumen. Now, what does bring eosinophil there? Which cell? As I show you in the beginning, there was two types of cells, the blue cells and the red cells. So the red cell you saw, they are eosinophil. And the blue cell are now here, we stain them with other marker, are T cells. And you all know that T cells is one of the cells that orchestrate all inflammatory response. So for any also drug to work, they have to work on these T cells. So we have to find a drug that can work on these T cells to inhibit some of their mediator, as you're going to see. So these are we call them Cd4 positive cell. They are sitting here below the epithelium, to the epithelium there, infiltrating all the airways there. And they orchestrate. يمكن انتم شايفين موسيقى the guy who the orchestra who really tell people what to do is those cells. They tell the immune response what to do and to bring those eosinophils. So how do they do that? They do that through a number of mediators. And you might say, why should I know about it? I think every doctor and every health provider should know about it, because now we have drugs that can block these things. So one of these mediators is called interleukin-5. And this is part of what we call the Th2 cytokines. Now, this interleukin-5, if there is no interleukin-5, those eosinophils that I described to you will not be differentiated and will die. So we can block anti-IL-5 with two ways, either by inhaled steroid, as you're going to see, or recently in the patient who do not respond to steroid with an anti-IL-5 cytokines that is now also available. So this is one of the major mediators that play a major role in the airways and in the pathogenesis of asthma. The other mediators that are also very important, we should know about them. I remember when I used to give this slide 10 or 15 years ago, people would say, why should we bother about IL-4 and IL-13? And again, I am sure you heard lecture from other people that now we have drugs which can modulate this IL-4 and IL-13 and improve asthma. Fortunately, as you're going to see, that steroid also work on them in most of the patients. So these IL-4, why they are important? Because they are important to produce the IgE. As you know, all asthmatic, most of them, they have the allergic asthmatic, have IgE. And with that, interleukin-4 and interleukin-13, the B cell will not be producing this anti-IgE, which cause usually IgE when it cross-link IgE to the receptor on mast cell. That is where you start to have sneezing. That's where you have to start to have release of histamine. That's where you're going to see the release of leukotriene. Those two cytokines also can also affect the epithelium. And as you know, in the epithelium, in patients with asthma, they have mucus hypersecretion. A lot of them, they have a lot of mucus. And now these two cytokines also can enhance the mucus production. And if you block them or modulate them, you will affect the mucus production there. They also prevent eosinophil from being enrolled inside the endothelium and going there. So together, these cytokines, IL-4, IL-13, IL-5, these are a group of a cluster of cytokines that are produced in excessive amount in asthmatics. While in normal situation, we have a balance, in asthma, we have an imbalance. There is more of a Th2. So can our combination effect can restore this imbalance, as I'm going to show you. So if a steroid work, it should work on these cytokines, it should work on eosinophil, without restoring this imbalance by blocking those one either with antibody or with drug, the asthmatic individual will not be relieved. Now, this group of cytokines, I'm sure people who are now reading about COVID-19, they all speak here about what we call cytokine storm. So a lot of patients with COVID-19, they die or they go into very severe COVID-19 because the body, these are all part of the immune system, and the body start to release all these cytokines, different cytokines, and these cytokines will be produced from different angles and will try to do, they do the damage in COVID-19. In asthma, what do? All these cytokines, they come there, they stimulate other cells, but at the end of the day, we will not have asthma if there is no effect of a smooth muscle. So as you know that the smooth muscle surround the airways, and the airways there is surrounded by there. So when it acts on the smooth muscle, what it does, it basically make this smooth muscle constrict. And that constriction need to be relaxed to get asthmatic better, or we have to remove the smooth muscle as we do in some of the treatment modality. So they work there. Not only they make the smooth muscle contractile, not only they make the smooth muscle proliferate, not only they make the smooth muscle migrate, but also make the smooth muscle. Now our concept of asthma has changed, is that the smooth muscle themselves, while contracting and while responding to these cytokines, they release more inflammatory mediators. So there's a pool of cytokines and mediator coming into the lung. And in any treatment modality, what we need to do is to really block this cytokine storm and take it from there. Now, for many years until now, and I'm sure Bassam will talk to you about it, is people don't care about what's happening in the lung. They care about symptoms. So patients would come with symptom, with bronchoconstriction, with difficulty in breathing, and then asthmatic. And then what we've been treating is the symptoms. Until now, a lot of doctors, they treat the symptoms. And they leave this inflammatory and remodeling process going on. They give inhaled steroid, they give bronchodilator, the patient get a little bit relief, the patient is not educated, they stop the treatment. A lot of patients, they ask us, you know, why should I stop my treatment? After 1 month, you know, he get better, then he get another attack. And because the process here, this is what we call top of the iceberg. You know, what we are treating is only the symptoms. Now, what we have to change our concept, and the new guidelines now is all about treating this pathological process that's happening in the airways through a better deposition, a better compliance, a longer treatment, and a most effective because if we don't do that, we will end up, as we are now seeing, with what we call difficult to treat asthma. we will end up with a multiple exacerbations. Every time he has an exacerbation, this patient, he will have an exacerbation, he will be relieved. And this exacerbation, as I always say to my student and our fellows, is that it is like an injury. If you have a skin and you injure it once, it will heal. The second time, it will heal with a scar. The third time, it will heal with a keloid. So the more we allow in this exacerbation, the more we ending up with excessive remodeling. And this is one example here, in an asthmatic individual, you don't want to reach to this stage where the smooth muscle has become so thick. Here, look, it looks like a tumor, but this is an asthmatic individual. Because if you do not maintain the treatment, if you do not control the inflammation there, you might end up with an excessive airway remodeling represented here in the smooth muscle. And once you get this one, it will be very difficult to treat it with any available drugs. Now, some patients, they respond with smooth muscle proliferation. Other patients, they respond with fibrosis. And that's maybe people who see the difficult asthmatic, they end up with a fibrotic process, and that time we don't have any treatment. So that all these pathological description that I told you about is really has changed the concept in the Gina Guidelines. You got to hear about the updated Gina Guidelines and the concept of all the guidelines, that our aim now have changed from achieving control of the disease. Because before we always speaking about achieving control. Yes, it is important, and we can use some drugs to do it, but also the other aim of every physician or healthcare provider is to reduce future risk. And to reduce future risk, we have to control inflammation of the airway and prevent the airway remodeling as much as we can by treating those patients well, because the more we're going to have of this exacerbation, the more there'll be instability of the patients, and there will be the lung function will be lost. And when the lung function will be lost, nothing can restore the lung function, especially if it is due to the airway remodeling or due to the fibrosis. Now, how can these two drugs work and why we are using them in combination? So, as you know, if we have an inflammation, the one that really can control this inflammation is inhaled corticosteroid or oral corticosteroid, which we don't advise. Those are the two major drugs that we've been using in most of asthmatic individuals. The other one is we have to treat inflammation and we have to treat bronchoconstriction. We treat inflammation with inhaled corticosteroid or oral corticosteroid, or sometimes with anti-leukotriene, although it doesn't work in chronic patients. And is these ones affect, is there an interaction between the two? Now, those two drugs, the LAMA and the inhaled corticosteroid, has been thousands of studies has been shown. And you're going to hear from Bassam the new Gina Guidelines. And now we introduce them very early, not in the step one, but you're going to see them that they are the major two combinations, the LABA and inhaled corticosteroid in controlling patients over 12 years of age. Now, how does a steroid work? We should know how does steroid work and why it doesn't work and how can we administer. Steroid work, we all give a steroid to a lot of patients, but a lot of us do not know how does it work. We should know because we will know also why it doesn't work. So when you give a steroid, let's say inhaled steroid, this steroid particle will cross the cell membrane here. This is a cell membrane. And then it will find something called a glucocorticoid receptor there. It forms a complex. And this complex will be translocated to the nucleus there. There is something called I know it's a bit complicated, GRE element. If that happens in any cell, a process of inhibition of mediators, inflammatory mediators, will be started successfully. You're going to see why it doesn't work in some patients. So this is what we want to achieve, is to get the drug to the cell cross the cell membrane, go to the nucleus, attach there. If this doesn't happen, no matter how much you give a steroid, inhaled steroid or oral steroid, the patient will not respond. I'll show you that later on. Now, if it goes into the nucleus, what does it do? You can see what I described to you about IgE, about all these inflammatory markers, about, the pathogenesis of asthma, as we said, is smooth muscle bronchoconstriction, it's mucus hypersecretion, mast cell activation, some epithelial fibrosis. These, the most important things, those eosinophils and Th2 type cytokines. Steroids work to prevent eosinophil from traveling to the airways by inhibiting the cytokines that are important for the recruitment of those patients. But not only that, steroids also work on mucus hypersecretion. And as you're going to see, it might even work on smooth muscle inflammation, certainly stabilize the mast cell and prevent this IgE from cross-linking with the receptors and decrease the vascularity, which we are seeing there. Now, how does it affect the constriction? Because it affects the epithelial cells. When we give inhaled corticosteroid, it really gets into the epithelial cells. And then it affects the mast cell. And as I spoke before, I told you before, once you get mast cell activation and degranulation, there is a release of a number of histamine, leukotrienes, other things. So when you prevent that, it will prevent the bronchoconstriction, at least the acute bronchoconstriction. So inhaled steroid or oral steroid, particularly inhaled steroid, which we use, have a double effect, anti-inflammatory and also affecting structural cells and could affect the bronchoconstriction, but it is not the best bronchodilator. Now, the other thing it does, steroids, and this was proved by many studies. As I show you the balance, in asthma, we have an imbalance, more of these cytokines and little of the Th1. We call them Th1 cytokines. So this is abnormal pattern. When we give steroid and it work, inhaled steroid, and it work successfully, this imbalance will go back to the normal balance that have. So there will be an inhibition of IL-4, IL-5, and IL-13, and an stimulation of the Th1 cytokine, interferon. So the idea here is to create the balance. And that's why steroid work. A lot of people don't know that, but if this happens, and if steroid work, this imbalance will be restored, and the cytokine storm will be sort of balanced, and the patient will be relieved. It does not only affect the lung. As you know, 80% of asthmatic have rhinitis. So when we improve the lung here, we improve also what's happening in the nose. And when we treat the nose, we improve the lung. I want you to know about that. Do not assess asthmatic without assessing the upper airways. Now we speak about systemic allergy, whole airway. We know that 80% of asthmatic have rhinitis. 40% of rhinitis have asthmatics. A good percentage of asthmatic have sleep apnea, which is another inflammatory disease in the nasopharynx and oropharynx. And that is also another benefit of giving steroids, because it's not only deposited down, but it might also affect the upper airways. And that is the basis of treating, maybe at one stage we'll speak about it, called the United Airway Theory. Now, the other drug that I want to touch, there's, as I said, we have two bronchodilators that we can use. We're going to speak, maybe Bassam will speak more of the LAMA. I'm going to speak more of the LABA here. So this one, what we call beta-2 agonists, they also work through a number of molecules here to inhibit the cyclic AMP there. And once they do that, they relax the smooth muscle. So we need to relax the smooth muscle, because the smooth muscle now is in response to it is all protective. The smooth muscle will get constricted. The cytokine will be released to protect the airway, but they do the damage. So you can improve the inflammation. Yes, it might improve a little bit, but you need for an acute thing, for an immediate effect, and for also prolonged effect, you need a bronchodilator. Ventolin has been used for a long, long time with all its side effects and misused by a lot of people. In the last few years, as you already been using, the lab has replaced it, and you're going to see in the new guidelines how we're going to use them even in the very early stage for the relief of bronchoconstriction. Now, those bronchodilators, a lot of people think they only relax the smooth muscle. No, they can do better things. What they can do, they can improve respiratory muscle function, make the smooth muscle more soft to relax. So it's not only relaxing it and not just improve the function. The other thing, it increase mucociliary clearance. Those patients with asthmatic, they have a lot of mucus accumulated in the airways. And every epithelium have what we call cilia. And those cilia, due to inflammation, due to asthma, they got a little bit lazy. So it increased the mucociliary clearance. It helps us. The inhaled steroid inhibit the mucus, but the sort of accumulated mucus, those bronchodilator will inhibit, will help us. And they might have, there must study, they show that they have some anti-inflammatory effect. So what I'm trying to say here is we need these two combinations in any treatment of a patient from moderate to severe asthma, persistent asthma, because we have to deal with the acute inflammation and with the chronic inflammation. And I really want to emphasize that LABA is not only working on the smooth muscle. It works on the nerve, it works on the vessels, and even on mast cell. So it has some anti-inflammatory. And now this is the one that without it, we will see more eosinophil, more T cells activation, more macrophages and dendritic cells. So we need this combination. Now, somebody will say, why should we have it in one system? Why we don't give fluticasone or give salmeterol or formoterol and why don't we give them? We used to give them alone. Why we are giving them now for many years, and now you're going to hear today in a new system, a new sort of application. Why we give them? Is there any benefit for that? And I think that also maybe can be discussed by the next speaker. But at the molecular basis, what we found is if you combine inhaled corticosteroids and beta agonists in the same can, in the same canister, in the same system, what happened is beta agonists expose the receptor for corticosteroids. They help them to be exposed, open those receptors, so they'll be more efficient in receiving the steroid. When we spoke about it before, they will receive the steroid and so it increases the efficiency of inhaled corticosteroid. At the same time, inhaled corticosteroid also working on the receptor here and enhance the effect of beta-2 agonists. So there's when you give them together, this is maybe additive effect. When we give them in combination in the same sort of system, there is synergism. And that will allow to maybe decrease the dose of both of them because there is a synergism. This LABA will improve the function of corticosteroid and corticosteroid will improve the function of beta-2 agonist. So that is, I want you to put that in your mind because a lot of patients, they tell you why we need a system that really gets those things together, the inhaled corticosteroid and the now, we've been using this combination for a long time, but we don't have a very good control of the disease. And in any combination, and today combination will probably help us in this. is we want to improve the deposition of the drug. You know, the drug, I mean, not all what we inhale go to our airways. And it doesn't go to all airways. A lot of those small airway will not really see those inhaled corticosteroids. So is there a system, and hopefully today's system, they will tell us that it will go to the small airway. Now, the other major problem, as I started, is the compliance. Can those drug company, can those new apparatus, can they help us to improve the compliance of the patient? This is a major problem in anything, that any drug will be only, a lot of the steroids and lab more or less are the same, but if anything can improve the deposition or improve the compliance or decrease the cost, because you know, this is when you have asthma, you take this drug, I'm sure Bassam would tell you, you don't take it for a month or 2 months, you take it for a long time, maybe for your life. So can we make those drugs more available? Maybe it's not very relevant to some country, but in a lot of, even in the state, most of the severe asthma we used to see in state and Canada, is due to patients who cannot afford the drugs. So they stop early or they don't use it. Now, if we improve all that and the patients is not responding, then we are dealing with something different, which is steroid hyporesponsiveness or steroid resistance, and that is probably is not going to be helped by anything. We have to use the biological drugs. And the reason steroid doesn't work is this, the right side here, it will pass the membrane here, it will go to the receptor there, but there is another type of receptor called beta, which will compete with this one, and when translocate would not recognize this element, So steroid will not work. If we reach to this stage, then we don't need to use steroid anymore. Now, fortunately, a lot of our patients are eosinophilics, and they have good receptors, you know, for steroids. And steroid work on them, on T cell on them. But we know that some cells, they do not respond to steroids. These are the neutrophils. And recently, as you know, we are now speaking about phenotype of asthma. We have a phenotype that have neutrophils. And those patients, they will not respond well to inhaled corticosteroids. Now, the same way, we are seeing there that, so we have a combination. Some patients have a combination of both cells. Some patients, they will have eosinophils, some of them have a neutrophil. And this is a new concept because we always thought neutrophil is part of COPD. And that's why we said COPD doesn't respond to any steroids. However, we are now looking into COPD, and there's more similarity than we thought before. So structurally, there is airway smooth muscle proliferation. You can see it in COPD, similar to asthma. There's basement membrane thickening. There's a fibrosis. There's alveolar disruption here, which you don't see here. So there is structure, but there is also inflammation in the two sides. But we always thought that inflammation in the two sides here in COPD are different. While here we see Cd4 and eosinophils, mast cell. Here we see more of CD8 and a neutrophil. That's okay. But why now in the guidelines we use inhaled corticosteroids in group D. We use LAMA. We use LABA also. We use LABA, and we use LAMA. And I hope Bassam will touch on this. Now, the reason why, so is there a room for inhaled corticosteroid combination with LABA to be used in COPD? I can tell you yes, because now we are dealing with phenotypes. While there's groups that are purely asthmatic and a group that is purely COPD, there's a group which have a characteristic of asthma and COPD. And the hallmark for that, if you see COPD, which an eosinophil, whether it is an eosinophilic COPD or one of those overlap syndromes, then that where there is a room for the combination therapy. A lot of people use it unnecessarily, but there is a very good room for those patients, and we know some patients respond. Yes, the major drugs that we are using there is LAMA, which also may be the company today, they're going to speak about a new product for this one, and that work on bronchodilation. But if you have COPD with eosinophil, then there is a very good justification for using the combined treatment of inhaled corticosteroid and LAMA. I know I finished my time, Dr. Ashraf, this is my last slide. What I want to leave you with the home message is now we are dealing with a complicated diseases, which is asthma and COPD. And the concept has changed from being a single disease to being a multiple phenotype. So you have to study your patient well. You have to know what type of inflammation is there. You have to understand the pathological basis because you have to prescribe the right drug for the right patient. Thank you very much.
Assalamu alaikum. Thank you very much. Yeah, I was waiting to be unmuted, but that's okay because that's better than the very social background we had at the beginning of the session. Alhamdulillah, things got better. And I'd like to apologize for the background noise when we started our session. I'm very impressed, mashallah, with the audience number. Professor Qutaiba, maybe you're muted now, but mashallah, we have people over 330 people so far, and people all the way from Japan to India to UAE and the Middle East. And that's very stimulating and exciting. I'd like to ask you in the next minute or so to write and post your questions on the chat box that you have downstairs. So any questions, please post your question or comment to the speakers or myself on this chat box. I'd like also to thank Professor Qutaiba for an outstanding summary and overview of asthma, the science behind treatment for asthma. He nicely went over the relationship between asthma and possible triggers for asthma, such as atopy, relationship with obesity, sandstorms, vitamin D. Then he nicely went into the pathogenesis of asthma at the cellular level, and he showed us that eosinophils in high numbers are something that is abnormal in normal patients. It is noticed that eosinophils are found in large numbers in asthmatics, and it is found in their large airway, in their small airway, and he also mentioned that you can see those eosinophils in the patient noses. Beside eosinophil, he also touched base on the Cd4 cells or the T helper 2 cells, and he outlined how those cells, which are very close to the epithelium, have a big and bad influence on the inflammatory cytokines, such as interleukin 5 and interleukin 4 and interleukin 13. And this explain the new era of biological treatments for severe asthma and how these biologics work on inhibiting these cytokines. Those inflammatory cytokines are bad, like eosinophils are bad, because they cause smooth muscle constriction, bronchoconstriction. And those smooth muscle, when they constrict, not only they constrict and make the airway narrower, but they actually lead to production of more cytokines and pro-inflammatory cells such as interleukin 5, 4, and 13. So it becomes some sort of a vicious circle. And at the very end, he showed that steroid work as an anti-inflammatory, mostly against those inflammatory cytokines, although it has some bronchodilation effect to a lesser extent. Beta agonists have more bronchodilation effect, although they still have some anti-inflammatory effect. And if you combine both of them, inhaled corticosteroids with beta agonists, they become synergistic and the effect can be additive. This is probably a summary of Professor Qutaiba. And I'd like to pose a question that came through the chat, Professor Qutaiba, and that is, you mentioned vitamin D which vitamin D, especially in children, below which level do you think kids are prone to develop asthma? And I can ask you, how about adults also? If you can please unmute Professor Qutaiba to address this question until I go through the other ones.
Now, look, we haven't, basically we haven't seen where is the trigger that they can start asthma. But if you look to the normal level, as you know, the normal level of vitamin D differ from one country to another, from one lab to the other. But on an average, if you look, it is not causing asthma. It is basically one of the environmental factors that trigger and make asthma more difficult, because, I'm not saying everybody who has low vitamin D is going to have asthma. But I'm saying if you are prone to asthma, or if you have a mild asthma, and you have vitamin D deficiency, then your asthma will be worse. Now, the bad news is you can replace vitamin D, as we show in the study, and the cytokine levels will go back. What happens is when you replace it, you're going to see inhibition of the cytokine inflammatory marker. But once you stop the supplementation of vitamin D, the inflammation go back. So you have to maintain the vitamin D into the normal level. You know what I mean? Now, what is the mechanism?
Immunomodulatory effect, Professor?
Yes. So it has an immunomodulatory effect. And we just got a paper accepted now. In fact, we show a very new mechanism for vitamin D. That vitamin D, in addition to basically inhibit inflammation, is also prevent remodeling, which is a new thing. In fact, at the culture level, at the basic life level, vitamin D can prevent the excessive proliferation of smooth muscle, fibroblasts, can prevent the release of fibroblasts of extracellular matrix protein. And that is for the first time we find anything which can modulate the extracellular matrix protein and the subepithelial fibroblasts. So what I would suggest is that, we have to do like we did, you cannot treat single patient. You have to treat the whole sort of, like you have to introduce vitamin D to school. We have to really make sure that our food has a vitamin D and maintain that level, because having it on a lot of people, everybody now come to the hospital, measure vitamin D in UAE, it's vitamin D is low. Now, he will take 50,000 units every week. He will improve. He will stop. He will get back to the. We don't know why. I was really surprised by the low vitamin D in a country like UAE or Lebanon or Egypt, where we have a lot of sun, where we have a lot of. But if we want to explain it, there's many things to explain it. But you see, because most of the sun that doesn't come through the face and the hand comes through the body. And also, I think the type of food that we are eating has a lot to do with the level of vitamin.
Professor, would you advise using inhaled corticosteroids as a reliever drug? I have a question here. Or just as a controller? You mentioned it has some bronchodilator effect.
No, I wouldn't say that is a bronchodilator. I said it has some bronchodilator effect through the mast cell. Steroid does not act directly on the smooth muscle. It does not have a receptor on the smooth muscle. Sure. It does that through the mast cell stabilizer. You remember before we used to use for treatment of asthma mast cell stabilizer, is that right? So yes. This one here, that it affects the mast cell activation and prevent the release of leukotriene or antihistamine. I will suggest that it can prevent the bronchoconstriction. That's why we always advocate for mild asthma. Let's say somebody have an exercise-induced asthma, he's going to do an exercise, or he's coming to come to the spring. We advise him to take inhaled corticosteroid to suppress inflammation, also to stabilize mast cell, to prevent it. But once it happened, I think the only one can be relieved is through bronchodilator, short-acting about that.
You mentioned remodeling and how vitamin D might have an effect on remodeling.
Okay.
Somebody's asking about the role of leukotriene inhibitors in asthma, with or without
Yes.
antihistamine. I have the question, but I remember going through some data of anti-leukotriene having remodeling effect on cellular level animal models, though.
You're right. You're right. You know, leukotriene, as you know, Montlucas in particular, the singular, has been studied extensively, and it was mostly studied in Montreal. That's why I call Montlucas, where I worked there for a long time. And we did a lot of studies on leukotrienes, anti-leukotriene. You know, regarding where should we use it, I think it has a good part to play in aspirin-induced asthma, in some of the pediatric asthma, in some, you know, now as guideline in the probably mild to moderate asthma. I think it will have some anti-inflammatory effect, but it doesn't work like steroid. It doesn't work through suppressing IL-4, IL-5 and inflammation. It works through inhibition of leukotriene, which coming mostly from mast cell and from. Now regarding remodeling, there was some studies that has been done before that show in animal model and at the molecular level that it might prevent fibrosis, which is a major problem of asthma. Steroid doesn't work on fibrosis. And however, when we took it to the human long, you see, it did not show any significant effect. Now, does that due to failure of it to suppress, or the remodeling has already happened? A lot of this remodeling happened in those asthmatic, and once it happened, it's one-way ticket, you know what I mean? So it does not do. So there is no role now of anti-leukotriene remodeling, but certainly has some role in some asthmatic and help to combine it with even steroids and LABA in some patients. Sometimes we give a combination. When you have aspirin-induced, it helps a lot also in the patient with upper airways inflammation, and in the pediatric population is very effective, and in some mild asthma.
This is COVID-19 era, Professor, and you mentioned cytokine storm. So of course somebody will ask about cytokine, COVID-19, and asthma. Can you link the three? In asthma, you already said there is cytokine problem in asthma, and COVID-19 has cytokine problem. Would you link? Is there any link between the two, pathogenesis of asthma and how COVID-19 would affect that?
Yeah. The cytokine storm in COVID-19 quite different from the cytokine storm in asthma. It's mostly IL-6 and TNF-alpha, which is also have a bad effect on, because IL-6 IL-6 and TNF-alpha are very pro-inflammatory generally. They are not a Th2 cytokines. So what happens is if we have asthmatics and who is not controlled, who have a storm of IL-4, IL-5, IL-13, and then come IL-6 and TNF-alpha, this is going to be a major problem. That's why in asthmatic we have to, people ask, shall we stop steroids? Shall we stop inhale? Shall we stop biological? No, you have actually to control asthma more, because you will decrease the burden of the cytokines. And in fact, in some early sort of studies and preliminary study, they were suggesting to use biological treatment that we use for asthma to really help those ones. And as you know, in COVID-19 now, dexamethasone is becoming recommended. And what does dexamethasone do? Dexamethasone inhibits a lot of these cytokines. So it helps both asthma and COVID-19. But the combination of two, IL-6, TNF-alpha, IL-5, IL-4, IL-13 is going to be disaster for them.
Thank you very much, Professor. Last question. I have lots of questions, but would like to move on with the program. And I'd like to ask you this last question about severe asthma. How would you find out somebody has severe asthma? What are the indications or implications? Yet this patient has severe asthma, and now I should think beyond inhaled corticosteroid.
Okay, so this is, need a whole lecture, but severe asthma. The paper that we published many years ago about the guidelines for severe asthma, I can refer him to the European Journal of Respiratory Medicine. But for severe asthma, you give them the maximum dose of inhaled corticosteroids and bronchodilators. And then you take all the comorbidity, you make sure that the patient is compliant, you make sure that you treat the GERD, you treat a vocal cord dysfunction, you have to exclude vocal cord dysfunctions, you have to make sure the patient's taking the treatment, give him the maximum dose according to the guidelines. And then if the patient, that is on the clinical level, is not responding, whether he has eosinophil or not eosinophil, mostly those patients doesn't have. These patients are at least, we call steroid hyporesponsiveness, and there's a degree, rather than absolute steroid resistance is very rare, So this is steroid hyporesponsiveness. In the molecular level, how do you know? If those patients taking all these inhaled steroids properly with the compliance, and we exclude all the comorbidities there, and we measure the sputum, or we see in their lung, there's still eosinophil coming there and cytokine expressed there, then those patients are not responding. So, but that's difficult to measure. People now using as a biomarker, and the biomarker now is either blood eosinophils. If you give a lot of steroid and the patient still have a lot of eosinophil in his blood and in his bowel or in his sputum, most likely those patients is not responding well to steroid, and you have to think of other biological treatment like anti-IgE, anti-IL-5, or anti-IL-4, IL-13.
Thank you very much, Professor. That was an
So severe
outstanding.
asthma varied, as you know, according to the study. Some people, they say 10%, some people say 20%, some people say 5%. But I think it's all about the range of these severe. So we have also maybe at one stage to discuss what is severe versus difficult to treat versus resistance asthma. But that might be for another time. Thank you very much.
Thank you, Professor. Thank you. Really appreciate it. I learned a lot, and I'm sure the audience enjoyed this talk. I'd like now to introduce our second speaker, my friend, Dr. Bassam Mahboub, who is a consultant pulmonologist and immunologist from Dubai. He's going to speak to us today about the latest and update on guidelines on asthma and COPD. Dr. Bassam?
Assalamu alaikum. Can anybody hear me?
Yes, sir. We'll
Okay.
mute ourselves
So,
now.
Basically, I will go through few messages that I would like to share regarding the update of COPD and asthma in terms of management. Along with that, I will touch upon what should we or we shouldn't do in the era of COVID. And I'll try to make it brief because there might be more questions, and I will start with asthma. So if we go for their latest guidelines on the COVID of April 3rd, they talked about all asthmatic patients are advised to continue taking their prescribed medication, particularly inhaled steroid and oral steroid. There is no evidence to suggest that these medications will keep people or will make people at risk of getting COVID. In the contrary, there are some of the evidence now coming that budesonide, specifically at the early stages of COVID, might be more beneficial, and we're waiting for more evidence into that. Now, the second thing is a written asthma plan. So this might be a common practice in an English-speaking countries. So maybe if you go to Canada, Australia, UK, and somehow US, you will find that people are doing this. But probably for the rest of the world, that was not, a common practice. We talk about it in the guidelines. But now, since we started the COVID, I would say 75 to 85% of my consultations are from here. Okay, so in the Gina Guidelines, like I said, the first message I would like to say is just to keep patients on inhaled steroid, or even if they want to be, or if you think or they're deemed to have systemic steroids, you have to continue taking this. There is no evidence that this will put them at high risk of getting COVID as opposed to not getting it. In fact, it is more beneficial. And like I said, there are some evidence that are waiting for more evidence to be solid about the use of budesonide at the early of COVID. whether you have asthmatics patient or no asthmatics patient. Now, okay. Now, the second thing is talking about the written asthma action plan. And I was saying that for most of us, we were doing this, but not that common. But since we started this, and especially since the lockdown in most of the world, since we have multiple audience from variable places of the world, most of the lockdown happened probably around this mid of March. And since then, we started to have more of the teleconsultations. In fact, 80% or 85%, and sometimes was 90% of my clinic would be a teleconsultation. So with that teleconsultation, we were always making sure that the patient writing a clear asthma action plan. So this is something that you want to tell patients. This is what you need to take. You take when to take the controls, when you think that you're not doing well, how to use the peak flow if you're having it or you don't, how to make a diary of your symptoms, and to combine this with your subjective feelings as opposed to the objective finding it, like doing peak flow. Okay, all right. So, and now we'll go about if there is anything different in this. So as you know, since 2019, we started to use the ICS LABA in a low dose for the asthma intermittent symptoms. So we kind of moved away from as needed, and we are starting to use this early on the mild asthma, where if you have symptoms, you can use as needed ICS and LABA. And then the second step, you can either go in a higher dose or you go in a fixed dose. Now, I don't know why I get problem, and yes, okay. So then you move to the next step, which is nothing changed on this, where you will just keep the low dose ICS LABA and add leukotrienes, or you go to the higher dose of the LABA ICS. All right, then the next dose will be, it's just basically the higher dose, and then you add LAMA. Once we add LAMA, we consider patient as a severe asthmatics. And I usually use LAMA for 4 weeks, and this is just a bridge before I decide whether I will go for TH2 low or TH2 high biologicals, which is a different talk. Then the next thing that came with the asthma and COPD is we are avoiding spirometry. In fact, since we opened the lockdown in Dubai in June, we said, okay, fine, we will do spirometry, but please come there in the morning, do the COVID test, make sure the COVID test is negative, and then 24 hours later, we can do the spirometry. And that's only as needed. But probably if it's not going to change the way that you will treat patient, and I don't think spirometry will change a lot, please don't try to do it, because if the patient has something or it has symptoms, or the patient has symptoms or no symptoms, but they are positive, then it will be a disaster. Now, one more thing, you have to make sure, which is probably out of this, you have to make sure whoever is doing the swabs for the COVID is confident and they are competent of doing this. Because one of the common, in fact, the commonest reason for a false negative is somebody who's shaking or not taking a proper sample. So in our department, we've trained all the spirometry and the bronchoscopy technicians to take this, and they took a certificate on that. So, and they are doing this every day, every morning, every shift. So we make sure that whenever the samples is done, because we face this a lot, that the patient will come to the emergency, symptoms goes with COVID, but then somebody took the sample were negative, but when we came and take it, it's positive. So avoid it, but if you absolutely have to do it, probably you need to take 1 or maybe 2 COVID tests before you do spirometry. Okay, now let's go briefly on the NICE guidelines about what you do and what you don't do. And this is a good document I've left here. So I've left the link here and you can download this. And in fact, I can give you the whole presentation. Now, the second thing, minimize the face-to-face. True, which is you do a lot of teleconsultations, but if you want to do it, make sure that your office has a good ventilation. Make sure that the patient is not having an asthma exacerbation while coming to you, because everybody will freak out and will think that this is COVID. You yourself, you wear the N95 and the patient has to wear the surgical mask. You keep the 2 meters. And like I said, if the COVID test was 24 hours of date, then you can do a spirometry if you need it. Otherwise, you don't do that. Now, the other things is the NICE guidelines regarding the biological treatment. So we did not stop our biological program for the severe asthmatics. And now, if you can see that you can give anti-IL-5 as an auto-injector at home. You can give Dupixent, which is a dupilumab, at home, except the anti-IgE, the omalizumab, they are working on something. But what we did, at least, we shift those people to the primary care next to them as opposed to coming to our infusion center. So you do whatever it is because you don't want to stop it because the severe asthmatic patient will get worse. All right. And another thing came also from the CDC, which talking about the same thing, is to make sure that the patient is having a good supply of their medications. Actually, I give them for 3 months. I make sure that they do everything. And whenever you have nurses who can get in touch with those patients, it will be good, because our program, the nurses has this WhatsApp group and they have a Facebook, and then they call, there is a number, there is a mobile phone just for this. And we were 24/7 in touch with most of our patients. So, and this is the way that you should do it, because you want to keep in touch with those patients. Now, let me just go over these 2 interesting articles, which is one when Jackie talking about a review articles about most of the asthmatics patients. So the message is there was no difference between asthmatics who got COVID and asthmatic who didn't get COVID. So what I was trying to say is the outcome of asthmatics are fine. I just admitted a patient last week who's a severe asthmatic with asthma, nasal polyposis. He was on Dupixent, which is a dupilumab, and he was absolutely fine. He only had a loss of taste and loss of smell. It was gone because of his polyposis, but was only the loss of smell. And he needed to be on the combination that we gave. His only manifestation was fever. Now, the fever went away, but then as any post-viral cough, COVID is another viral that can trigger the bad cough with asthmatics. I just admitted another patient, asthmatic, who I saw 2 weeks ago. She was doing absolutely okay on ICS LABA. She got the COVID, symptoms were fine, but then she's having this nagging cough. What do you do with this? Well, you increase the ICS LABA as needed, if that's okay. You give steroids, that's absolutely fine. And you give a cough sedative. I use codeine, and I use something related to the codeine to stop the cough. And sometimes I use inhaled xylocaine, and it's whatever you feel that it is okay, you can use this. All right. Now, another interesting paper which talked about the inhaled steroid downregulation of the ACE2 receptors, and that's in COPD, but also it was found in asthma. So probably this is going to be a hot area. I was talking to David Price. I'm involved with him in a severe asthma registry, and we were talking about the outcomes of those severe asthmatics. And like I said, it seems to be that they are doing the same. So it didn't affect their mortality or the course of the COVID. But when we think that those people who are taking the inhaled steroid, they're kind of having this protective mechanism by low ACE receptors. And we know that the COVID-19, they needed the ACE receptors to be able to go inside the cells. Now that is for asthma, and let's move quickly to the COPD. So the first statement came from the GOLD, saying that there is no mounting evidence to say that giving people inhaled steroid or systemic steroid, although we know the risk of pneumonia, there's no evidence to say that those people, they were at risk of COVID because of this. In fact, it was more of a bacterial pneumonia than the COVID itself. So the treatment plan was to keep patient taking their medications because your aim is controlling the COPD. Your aim is controlling asthma. And then we talk about COVID. Steroids, please give it as much as you think it is, but their risk of having bacterial pneumonia is the same risk before or after COVID era. So just to remind you about the A, B, C, D, and what we know that the D and B are the ones who have more exacerbations. And nothing changed in terms of the in terms of what you give. So you start with the bronchodilators with A. Somebody would have mild symptoms and normal spirometry with not much of lung function changes. And then you go to B, where the exacerbations are more, but the lung functions might be preserved. And you go to C, where you don't have much of exacerbation, but there is obstruction. And then you go to the D, which is they have obstruction and they have exacerbations. And actually, well, I think for the rest of the world and for most of the world, and I think we are no exceptions here, at least in the Middle East, we pick most of our COPD in the D at the D level. And I think Ashraf Zahabi, our chairman, already published something about this a few years ago. Now, I don't want to take you through this, but this is what you do for the stable one, which is in your left of the screen. And then the right one, this is what you do on the right of the screen. And there's nothing different whenever you treat it before the COVID era and after the COVID era. The main aim is to control your airways, is to control asthma and to control COPD here. As you know, during exacerbations, maybe patients find it easier to use nebulizers as opposed to the inhalers. Now, self-management exacerbations, and this is where medicine is an art more than a science, and this is where personalized therapy. So there are some patients who do very well with antibiotics. You know them better than me. You know your patient, and the patient knows themselves. They will come say, no, I need the antibiotic because I get better with that. And we know from evidence there are small groups of them, they do get better with antibiotics. So this is the one that you start, the tailored medication. I think if they are not diabetics, or if the diabetes is under control, even you can go ahead and give them few days of steroids if you think that this works always, because during the COVID time, it was almost impossible for them to trust coming to the hospital. And like we were wondering, where were our other pneumonias? Where were our COPDs and sleep apnea? Probably they were hiding, they were scared. Excuse me. So, and then you explain to the patient, so this is like an COPD action plan. If you don't have this, then you do this, then you can use that. And then if you don't feel better, you come to the hospital. Smoking cessations is always welcome. And there was some conflicting things about the effect of nicotine, not smoking, because smoking is not only nicotine, you get tar, you get chemicals, you get toxins, you get carbon monoxide and all other things. But nicotine itself as a drug, there was some evidence that it has a favorable effect with regards to the ACE to the ACE receptors. I don't think the message should be, please keep smoking. So smoking cessation is always welcome. Oxygen, by all means, if you are taking it, keep taking it. If you're not taking it and you are on the verge, probably use it, and it always works. Now, oral prophylactic antibiotics, and this is again tailored. You know your patient, the patient don't know themselves. If they are already on it, start them. But don't give it to them because you think this will prevent COVID, because there's no evidence into that. Airway clearance. This is always a good idea because we know that stacking of these secretions gets a secondary infection, and there's a good data to say that they have overgrowth of antibiotics, and it has also to do with their microbiota, which is also another topic. But if they don't know how to clear it, teach them. If they know, tell them to do it more frequently. All right, so probably I'm coming towards the end of my talk. As I said, I'm going to be making it short. This is a very nice study, which is a meta-analysis that done by a group in Saudi, in Jazan. And actually, I did not think that the Jazan people will have this, but because most of their names, I'm not so familiar with it. So they did a meta-analysis of looking at the at COVID/COPD and smokers. So the prevalence of smokers among the studies that talked about about COVID was around 9 to 10%. This is the message number one. Message number two, the risk of mortality is 7.5% more than others. Finally, if they have other comorbidities, the risk of severe COVID comes to 63%. I should end by, we are doing a very nice algorithm that I shared it with our WhatsApp group from the Emirates Thorasic Society, which using the clinical parameters of 2017 patients with COVID. And we came up with artificial intelligence algorithm predicting severity and predicting length of stay or length of stay. We can probably share it in another talk, but this is a talk about launching another kids in the block, which is ICS LABA and LAMA, which is, as you've seen from the two talks, that they have a great evidence. I will probably stop here. And if you have any questions, you can ask me. Thank you very much.
Thank you very much, Bassam. That was a wonderful overview and update. I really would like to thank you for the articles that you shared with us. It's becoming very hard nowadays to catch up with the literature. And I think you did a great effort trying to share the most recent and most relevant with our colleagues from all over the world, I would say. Bassam, and I'd like to start where you ended, where you mentioned about the risk of respiratory diseases. Here I have lots of questions. Allergic rhinitis and higher risk of dying from COVID-19. Asthma and higher risk of dying from COVID-19. And in your article, the Jazan paper, COPD and high risk from dying from COVID-19. I came across an article, Bassam, that came from the USA, and I think it was in New York, if I'm not mistaken, not too long ago. And they actually said chronic respiratory diseases in general are associated maybe with higher mortality from COVID-19, but asthma was not found to be really very significant contributor to this increased mortality. Like you outlined from the Saudi paper, the COPD, bronchiectasis, respiratory failure are the big, the culprit, the accused chronic respiratory diseases. But the mortality from the New York cohort was only 5%, not too far higher than any other diseases when it came to asthma. Would you like to share your experience or your thoughts about this?
So we went through our data, which is probably around 5,000 or more, and the numbers of the COVID with asthma were low, and their outcome was very similar to non-asthmatic patient. However, the COPDers, as you know, and we published this before, by the time they are in our record, they already have hypertension, they have diabetes, and they are older age. And the more severe they go into their classification of COPD, the more mortality they have, and then the more likely they will get a complicated COVID severe disease. Allergic rhinitis is actually nothing. There is no difference
Thank you, Bassam. And
Ashraf, can I just comment on this?
yes, Qutaiba, please go ahead.
So let me just put the thing there, because those papers which they look on asthma, all of them, those papers, they look on control asthmatics, a mild, moderate asthmatics. So if the patient was on anti-inflammatory, well controlled, then that will help him to be actually less even prone to the sort of, the mortality is due mostly to the sort of the cytokine storm. So, but no study, I haven't seen any study which look at the message here is that we're trying to say is that keep asthma controlled during the COVID-19, because as Sam was saying, some people, they worry that steroid might decrease the immunity of the patients and they should not use it. So I'm sure if we are looking to patients who are asthmatic, who are not well controlled, the mortality will be much, much higher. You know, because it makes sense that to see that if there's already something happening and with an additional sort of an insult, those patients will not do very well. You know, so I think we should just speak about controlled, well, who are taking their medication regularly, and the message that we should give to the people that they should maintain a good dose of anti-inflammatory during the COVID-19.
Sure. Thank you.
Yeah, agree.
Bassam, I have a question here about inhaled corticosteroids. Do they have a role in exacerbation when it comes to mild intermittent asthma? As you nicely outlined in the recent update of Gina Guidelines, now the guidelines encourage that inhaled corticosteroids has to be taken whenever a short-acting beta agonist is taken for mild intermittent asthma.
Yeah, I mean, the short answer for this, yes. There is a good evidence now to say that using it, even in the mild and in the mild intermittent, it serves better outcome as opposed to short-acting bronchodilators alone.
And for our audience now, as you may know, this change in the guidelines came in the last year and 4 months roughly. So this is where Dr. Bassam is trying to share this new information. And we also have a related question here, and this is for both of our dear speakers. Are there any differences between budesonide versus fluticasone, and or is there an advantage for one over the other? And I'll start with Bassam.
Could you repeat that question again?
So for both Professor Qutaiba and Dr. Bassam, I'll start with Dr. Bassam. What is the difference or advantage between fluticasone or budesonide inhaled corticosteroids in asthmatics?
I think from the pooled data, they find a difference in the groups of COPD. But when it comes to asthma, I don't think, unless Prof. Qutaiba knows more, I mean, I'm not aware of a big difference between them. In fact, the only change was on the Fimitrol and the Salmetrol when it comes to asthma. But in the Swedish study looking at the COPD, yes, they found more frequency of pneumonia among COPD with fluticasone as opposed to budesonide.
Now, one of in the biological level, you know, fluticasone has more bioavailability, and that's why the efficacy is higher, but has more bioavailability. So that's sometimes is good and bad, but has more bioavailability. The budesonide, you know, have less bioavailability. Now, the other thing is about, it's not only the budesonide versus fluticasone, is the way we deposit that. What sort of, you know, what sort of system we are delivering that in, you know. That has, you know, at one stage, if the early fluticasone, like the Serotype, the budesonide, you know, with the Sympicor, that has much better deposition because of the system we use, you know, the urban inhaler versus the other one. So I hope that with the others, you know, when you use a different system, and also when we use a different molecule of the steroid, the size, as you know, the deposition depend on the temperature, the flow, and the size of the particle. I think regarding as a steroid, that it's only the bioavailability which could be, work on two sides. But I think the most of the studies show the difference is the system that by which we deliver those two drugs.
Thank you, Professor. Bassam, there is a question about the triple therapy in COPD. You nicely went over the new update in COPD guidelines and how when you think dyspnea, you can combine two bronchodilator like LABA/LAMA. And when you're thinking there's a bigger problem of an exacerbation, you're thinking of adding inhaled corticosteroid, for example, to the bronchodilator therapy, depending on what's the most significant symptoms a COPD might have. How about triple therapy, Bassam?
You mean triple therapy in COPD?
Yes, sir.
Okay, so if you think about it, so you think of two ways road, so which is going and back. So if you go on the right side, you're going forward, and you go on the left side. So ICS, it starts early in the asthma. So if asthma is on your left side and COPD is in your right side, think of ICS as early on the left side comes in the treatment of asthma, and LABA comes later. It's the opposite when it comes to COPD. You start with the LABA/LAMA first, and then ICS comes later. And as Prof. Qutaiba said, probably at the end of the day, you will find severe asthmatics are behaving the same way that the COPD do. So triple therapy, yes, there's a good evidence of LABA/LAMA better than any one of that alone. And if the patient is having exacerbation, yes, ICS will be a better choice. And I think most of us will start using now the once daily triple therapy. It'll be easy, and it'll be for most of our patients at least.
Ashraf, just if I can add to this one,
yes, sir.
in those difficult cases when you do the triple therapy, the more severe the case, the more chronic the case, the receptors for, as you know, LAMA use different receptor from LABA, okay? And the mechanism of action, they're quite different. One act mostly on nerve, the other act mostly on the muscle. So when we have those chronic cases like the severe COPD and even severe asthma, you try to really tackle all these receptors to get a good effect. Now, as you know, LAMA has recently been used also in severe asthma, because not only of the bronchodilator effect, but again, in study by Nicola Hanania, because also it has some anti-inflammatory effect. So I think when we have a case which is, I don't know what Bassam think, but I wouldn't suggest to use those one in moderate even to severe, to very severe or very severe COPD, because those are, we use them at least in severe asthma just before we go to the biological, we add the LAMA. So I think we try to occupy every receptors and get more synergism when we add the three of them together in those very severe chronic cases in adults.
Sure. Thank you. I would also I would read a question that came in the chat group just to make a point out of it. It says, how much is the burden of COPD in pediatric age? And is there explanation for its low burden? I would here maybe make a point, and I may I may take my speaker's opinion, but I think this is an important question because I was trying to do an audit from the ICD coding in the health authority and for COPD, and what I found that there was a lot of patients who were labeled with COPD were pediatric population. And this question comes to remind me about that incident. And I'd like to, as you all know, my colleagues, COPD is caused in 80% of patients. Yes, we do see COPD in patients who never smoked, and we think maybe it's related to environmental pollution or other things, but in most of the time, it's a smoking-related disease, and usually patients would smoke for many years, 20 years or so, before they develop COPD. So I would be cautious labeling pediatric population with COPD. Bassam or Professor Qutaiba, one of you want to comment on this?
Yes, I think a lot of these people, the very young people who are labeled as COPD, are fixed airway obstruction. They are asthmatic, severe asthmatic with fixed airway obstruction. Although the recent study have shown that actually the predisposition to COPD start in very pediatric population. There's a paper which has been published by Benjamin from McGill, which show that the thing which, as you said, there's some patients who are not exposed to smoking and they develop COPD. And the determination of that come from the early stage of those pediatric population, not genetically, but about the structure of their lung and then the development. A lot of those children, sometimes they are born with the lung is not very well developed and the branching. Very interesting paper. So they show that those children or babies who have some problem with the branching and the development of the lung, they are more exposed to the COPD irrespective of the smoking. So I don't know, maybe you saw, but I'm not pediatrician, I don't know. I mean, to have a clear-cut COPD in a very pediatric population probably is not that common, or not, I don't think, but I think it's a severe asthma because remodeling start in asthma and if this asthmatic affect the small airways due to the mother is smoking and, the children, they're a small airway, they get affected more than the adults or they are exposed or they are allergic. I think they will be mistakenly labeled as COPD, but it has probably a lot of structural changes, maybe some fixed airway obstruction, they label them like this.
Thank you. Thank you very much. Dr. Bassam, do you want to add anything about this?
No,
part?
I would just like to say that as Prof. Qutaiba said, there are some evidence in some paper, I think by Martinez, who talked about COPD starts from childhood. But I just want to say that the evidence of fixed obstruction among kids could be other things. I've been treating a patient that I thought it's a young girl with a severe asthma, and she was not improving. I thought that this is a small airway asthma. She was not improving. And when we took a biopsy, she had bronchiolitis obliterans. So the reasons could be different among pediatric groups. And I'm not a pediatrician, so I cannot say much.
Sure. Thank you very much. I'll have to say that I'm getting a lot of compliments thanking both of our speakers, Professor Qutaiba and Dr. Bassam. And I enjoyed myself the beautiful journey from basic science with Professor Qutaiba all the way to the most recent literature review and guideline update with my colleague, my dear friend, Dr. Bassam. And thank you very much, Professor Qutaiba and Dr. Bassam. And I'd like now to introduce our third part of the sessions, and that is Dr. Wa'il Khattab, who's going to be going over the portfolio and the news of Exeltis being in the Middle East recently.
Dr. Ashraf, it's really great honor to have this great panel, Dr. Ashraf Zaabi, Dr. Bassam Mahbub, Professor Qutaiba. This is a big names in the field of asthma. And when it comes to asthma, when it comes also to Exeltis, I would like to, first let me share my screen. So let me start with why we are here, why Exeltis, and why I have been selected this to be like a kind of Exeltis simplifying the management. What our speakers perfectly mentioned now about the two main era that we are speaking about, which is asthma or COPD, both are very complicated diseases. And now it's time for how to simplify this. And one of the most important topics that Professor Qutaiba has mentioned during his presentation about the management of asthma was the compliance of the patients and affordability. That's why Exeltis is there. But before going to how Exeltis simplifying the management of both diseases, let me first give you a hint what's Exeltis and why we are here. So in the beginning, let me show you Exeltis. Exeltis coming from a mother company called Insud Pharma. And what is Insud Pharma? Insud Pharma is a company founded in 1977 in Spain, exactly in Madrid in Spain. And that's why we still have our headquarters in Spain till today. Our footprint is available in more than 50 countries. And under Insud Pharma, there are 3 sister companies: Chemo Group, Exeltis, and mAbxience. Chemo Group is a company mainly dedicated and responsible for production and selling of the APIs, which sharing these APIs with most of the pharma company that it's ever known in the field, like Novartis, like so many other pharma company using their APIs from chemo. And then come Exeltis. Exeltis is a company that it has the sales and marketing and R&D team. So this is the company which is the face of the chemo in the industry, which is the Exeltis. And then come the mAbxience. mAbxience is a techno company mainly specialized in the biosimilar. So these are the 3 main companies under the Insud Pharma. Where are we? Where are we in when it comes to the footprint of the Exeltis? Exeltis is available in more than 40 countries across the globe. 40 countries with more than 300 products, with more than 4,000 professionals working for Exeltis. So from US to Latin America, to Asia, to Europe, to Middle East, Africa, we are in everywhere. But we in the Middle East just starting, we in the Middle East just beginning in from 2017, just from 3 years we are existing in the Middle East. And now for what is the era of that we are specialized in when it comes to so for Exeltis in the Middle East, we are in the Saudi Arabia, we are in UAE, and we have the plan to be extended to the North Africa, Egypt, Algeria, and others. In Africa, Morocco, South Africa, in Latin, in US, in Europe, in Asia. So we are in most of the countries. But why we are? Why Exeltis is there? We have a very simple mission for Exeltis. Number 1 is to make a difference. Make a difference to make choices for the doctors, choices for the patient, and the most important is to develop a new product in different therapeutic areas, and to improve lives, to enhance the quality of life. This is why we are existing as Exeltis in the field. We are specialized in multi-therapeutic area, but the main therapeutic area that we are specialized in is the women healthcare. Most of our hormonal product is serving the woman health, from the contraception, the emergency contraception, the postmenopausal hormones, the emergency contraception, and for the prenatal care, and so many other products specialized in the woman health. When it comes to respiratory, we have the 2 main products that we are launching today: Fludaldu for the bronchial asthma, and Nimotropio for the COPD. CNS for 2 main products that we have: Epixil and Velexil for the schizophrenia and depression. Dermatology, also we have a product for dermatology. So it's multi therapeutic areas that we are working for. But let me go back again to the main question. Why Exeltis is considered as the main partner of choice? And the more question to comes is, the field or the market is full of products for asthma and for COPD. Why are we there? Why Exeltis wanted to enter this field? And the question is coming from the study that Dr. Bassam himself was participating in early, and it was published in Annals of Thoracic Medicine, and it was about asthma control. The question again is, are the patients in UAE are controlled and satisfied? And if we take this as extrapolation to other patients in other era, are the patients are satisfied or not? And let me take it as it is. The control of asthma in adult in UAE, asthma inside and reality in the United Arab Emirates. And I will take the conclusion as it is, as it has been written by the authors. This survey showed that the current level of asthma control in UAE is far from optimal. Therefore, it is necessary to increase the awareness among patients and update doctors about asthma control guidelines. And this is what we are doing today, is make this kind of awareness program for the doctors and for the patients. But again, why are we there? Why we considered Exeltis as very good choice as a partner in this? We are trying to simplify the management of the bronchial asthma and the COPD. How we are doing this, how we simplifying this is not. So let's go back to the what Dr. Bassam has already presented in his presentation, that the Gina guidelines, and how can we allocate the Fludalt in the Gina guidelines. Of course, Fludalt is the best fit step 3 and above. Step 3 and above for the cases from the moderate to severe asthma. And this is because of the combination, the unique combination of the Fludalt, which is the fluticasone and salmeterol. But why in the step 3 and the step 4 and step 5 also for asthma, Fludalt can be perfectly fit? Because one of the main points that also Professor Qutaiba has mentioned, which is the synergy between the component, because the synergy between the component of the Fludalt is unique. It's a component between the fluticasone and salmeterol. And the synergy between both, that salmeterol can allow high level of fluticasone intracellularly, which make this more effective. So fluticasone to work perfectly and to work more, it should be intracellularly. And this is what salmeterol help and support by increasing the concentration of the fluticasone inside the cell. And this is give the Fludalt the unique effect and unique action. That's why when it comes to the control of asthma, we can say that fluticasone with the salmeterol, considered both of them as the perfect fit together, because this can give more and more control of the patient and control of the asthma patient. And now, for this kind of control, we can see that with the fluticasone and the salmeterol together, this can give the right control of the patient. And this control, of course, can give more quality, more better quality of life. And this is what we need the patient to. As we have mentioned before, that the patient had the full right to breathe. And to breathe well, he will enjoy the life. He will enjoy to breathe and to live the life as it should be. And now, from this point of the quality of life that the fluticasone or Fludalt support the patient with, let's go also again to one more point. Yes, this is about the other product, which is the Nemotropio. Nemotropio is tiotropium, which is very well-known molecule when it comes to the management of COPD. And again, why Nemotropio? Again, why do we are repeating the same product again if we have one in the market? I can say it is not the same, it's even much better. Why we are saying that? Because when we have our perfect bioavailability study that comparing the tiotropium that we have in Nemotropio to the test product which is available in the market, we have found that both are the bioavailability, both are the same when it comes to the bioavailability. But the big but here, the tiotropium available in Nemotropio is 13 microgram that deliver 10 microgram versus the others available in the market is 18 deliver 10. So it's perfect product that with less residue. When it comes to Nemotropio, we can easily say Nemotropio is bioequivalent to the test product that available with less residue, and this can give the patient more relief and can also support the patient to live the quality of life that we need this patient to. I will go back again here to one very important element that Professor Qutaiba has mentioned, which is the compliance of the patient. And when the patient can be compliant, the patient can be compliant when he is in control with his patient, with his disease. And for the Nemotropio and for the tiotropium as a molecule, there is 1,000 of publication that there to support this. But I have selected just one meta-analysis concluded that in more than 23,000 patients in more than 22 studies, and the author conclude that this review showed that tiotropium treatment was associated with significant improvement in patient quality of life. This is the point, the quality of life. We need the patient to live the good quality of life, either by the Fludalt or by the Nemotropio. But the most important point is the patient education. What that means for patient education. Patient will not be able to use something he find this difficult to use. But when it comes to the two products, either the Fludalt or the Nemotropio, we can find that the device that we have selected to be used in the both product is the basic one, which is the very easy one, the one that can really the patient can really easily to use. And the capsule or the capsule that containing the Fludalt or the Nemotropio is a transparent capsule. Once the transparent capsule is in the device, the inhaler that the patient use, the patient can make sure 100% that he already used the medication perfectly and up to the maximum. Other than other product, which is the device is just closed and the patient is not sure if he used the medication or not, these are the two devices. This is the one for the Fludalt, this is the one for Nemotropio, and this is the capsule for both. It is transparent capsule, which once it is put in the device, the patient can make sure that the patient has used the dose up to the maximum. And one more point, Professor Qutaiba also was mentioning during his presentation is the affordability. For the Fludalt and the Pneumotropio, with the high European quality of manufacture, the price of both product almost 50% of the originator product that is available in the market. So we, as Exeltis, providing two products, very simple to use, very effective because the combination is highly uniquely selected. The manufacturer is high quality, European quality, and very basic, easy to use, user-friendly devices. The patient will make sure that he already used the medication because the capsule is very transparent and it's very easy, no hassles, nothing behind. That's all from my side. Thank you very much. And I will leave the floor now for Dr. Ashraf to complete the webinar.
Thank you very much, Dr. Wael, for your overview. And thank you very much for organizing and arranging this beautiful evening on asthma and COPD. And I wish you all the best of luck and in the region. And inshallah, we see you participating with us in medical research also, as I understood from you, your interest in supporting medical research in the field of respiratory medicine. I would like to thank our speakers again, and I'm very pleased with the big turnover from the audience and their interaction with us. And if you'd allow me at the end, I'd like to thank Exeltis for their kind sponsorship. And I would like to also thank MCO, our event organizer, for their beautiful organization. And inshallah, I'm looking forward to see you all in future meetings in the near future. Assalamu alaikum.
Thank you. Thank you.
Thank you, Dr. Ashraf. Thank you very much.
Thank you, Dr. Ashraf.
Thank you very much. Assalamu alaikum. تصبحون على خير.